we have with us at the moment two of our three scheduled panelists. We're not quite sure what's happened to our third, but hopefully he will appear in due course. So I'll begin by asking our two existing panelists to introduce themselves, starting with you, Paolo. Would you like to just say a few words about yourself?
Hi, I'm Paolo Milia. I'm a neurologist. I'm the chairman of Rehabilitation and Robotic area of Prospero Institutes in the middle of Italy, near the Perugia city. And at the same time, I am the vice president of International Society of Digital Medicine and co-editor-in-chief of Digital Medicine Journal. I'm really happy to be here with my friend David, my friend Lucia, speaking about technologies applied to neurological disorders. Thank you very much. Today in Italy is the June 2nd, is our holiday where we decided to leave monarchy and to become a republic. So thank you very much to all of you.
Okay, thank you for that, Paolo. We are still a monarchy, and I can't see, unless anything goes disastrously wrong, that we will be a republic in the near future, but you never know, you never know. So, Lucia, would you like to introduce yourself?
Yes, thank you. Hello to everyone. My name is Lucia Pannese. I'm the CEO of an SME based in Milano, so this is northern Italy. Quite some, what should I say, 500 kilometers north of Paolo, where he's living. And Imaginary is specializing in serious games, and especially games for health, but I think we will get into the topic very soon. So thank you, David, for inviting us.
Okay, thank you very much for those introductions. I will just share the screen again and give an outline of the discussion this afternoon. Hopefully, Michael Morgan-Curran from My Cognition will be joining us later on. But the plan is we've already covered the first two items. Panelists have introduced themselves, and I'm going to start by asking Paolo to talk about some physical rehabilitation solutions. And this is where Lucia's company, Imaginary, has an overlap between both physical and cognitive rehabilitation. So when we're looking at physical rehabilitation solutions, I'll put a couple of pictures up on the screen. One shows an exoskeleton solution, which is what Paolo is primarily going to be talking about. And the other one shows an example of a game that developed by Imaginary. So two different types of solution. I'm going to stop sharing that now. And Paolo, would you like to say a little bit about your clinic and your involvement in rehabilitation? What's the background to it all?
Yeah, thank you very much, Terry, because all the time you are targeting the items that are really, really clear in these times, especially where COVID is punishing us, I think, because we have treated this all around world like was a rubbish. So technology, I think that we have never seen that technology is quite important in our life. We have started to work with Zoom meetings. My daughter and my boys are working all the time through Teams, so following the school, also being at home. So technologies now is everywhere, especially during our disease time. So if we have a look at the World Health Organization, we can see that neurological disorders and injuries account for about 6.3% of the global burden of disease. And when we are speaking about global burden of disease, we are speaking also about disability adjusted life years. And this means that in the 6.3% of neurological disorders, about 55% of patients have a disability due to a cerebrovascular disease. If we consider cerebrovascular disease with spinal cord injuries, we are speaking about 52% of all disability around the world. And if we are speaking about disability, we are speaking about the 50% of the world population. So this is quite important when we are talking about rehabilitation, because all the time we have met each other, we are speaking about survivors. So ICU, emergency unit, stroke unit. We are speaking about people who had injuries, who had stroke, who had heart attack, and now are able to live again. But we are creating survivors. These survivors need to be placed again in a social way. This is the main theme of rehabilitation. So in the last 2 decades, neurorehabilitation made an impressive increase of technology, because we are speaking about really severe patients affected by paraplegia or tetraplegia or hemiplegia or hemiparesis. So really tough motor disorders. So what we have in our main goal when we are doing rehabilitation, we have just 2 items. Or we relearned to move again, or we trying to increase or improve what is the movement at this time. So we cannot do anything of different. And if we want to move again, we need technology. Otherwise, our PTs will be under a terrible work that will not be able to do again, because we are working with really, really tough and serious patients. This is really nice, because today we are speaking with a visionary man like you, and with an engineer like Lucia, and with a neurologist like me, and we are still waiting for another person. And this is the main theme that we have to develop in the future, because we need to cross-act all the figures that can be able to improve the future of our patients. So in our institution, we have about 112 beds related both with neurological disorders and orthopedic disorders. So when we are speaking about neurological disorders, we have about 500, 600 patients admitted in our hospital affected by stroke, spinal cord injuries, or neurodegenerative disorders like multiple sclerosis and Parkinson's disease as well. Or we have other neurological disorders, acute neurological disorders like polyneuropathy or Guillain-Barré syndrome. So all neurological diseases that then affect patients with motor sensory disorders. Okay, so what do we have to do? Stand up and try to work again. So this is our main goal. To do this now, after 20 years, technology is giving us a really great opportunities. In 1998, we start to work with grounded exoskeletons. Then we developed the end effectors. And at the end, we are speaking about wearable robots. Michael is coming. You want to say something, David?
Well, I found Michael in one of the participants, so he'd logged on as a participant, and I didn't spot that. I just thought it might be the case, so I've just found him. I promoted him to be a panelist, but it looks as if he's got his camera switched off there. But he is with us, so he will join us in due course, and I'll give him a chance to introduce himself. He might be having a cup of coffee, so.
Okay, I can go on. And so we are speaking about technology applied to upper and lower motor disease, or better is upper and lower disability clinical approach to neurological patients. This means we are working with robots applied to arms and robots applied to legs. That needs to increase the single movements of our patient. That cannot be done in a special way with our PTs. This is why technology is quite important with our approach, okay? Because the aging of people is giving us the opportunity to treat patients also after 60 years old time when they are affected by other pathological disorders. And we are treating in our hospital patients coming from the stroke unit, coming from the spinal cord units, and we have to give them an answer. That means coming back to their own social life. And it is not the truth at the moment, okay? Because about 80%, 85% of people affected by spinal cord injury is not able to come back to their own work. And people affected by stroke is not able to live in a normal way in their own family. So what is the main answer that we can give them? In my hospital, in my institution, I have 3 different wearable robots, 3 different exoskeletons, Exo, Indigo, and now the Felix. This is the new Italian exoskeleton. Okay, I'm treating patients for 2 months. I'm giving them the opportunity to come back to their own position, starting to work on the ground. After all, what we are offering to our patient. This is why I'm trying to work with my friend Lucia Pannese, because we are trying to find a roadmap back to be rehabilitating at home as well, because technology is giving us the opportunity to treat very severe patients in our hospital. And this is quite important, to be treated within a neurological, very trained clinical hospital. But soon after, we have to offer easier technology to be treated at home. So the main goal of our discussion should be that, okay, now we are able to save the life of people. We are creating survivors. We are treating patients in a very sophisticated way with high-level technology. Every kind of technology, David. In my hospital, you can find the ground exoskeleton, the end effector, and the wearable robots. We are working in a translate way. I'm not speaking about the best robot is this, the best robot is that. We are just speaking with all technology to increasing or to achieve our main goal, that is give our patient the opportunity to come back home. But after all, is home a safe where to live, or he has to come back to a rehab unit? With Lucia, we are speaking about coming back to home and being treated with easier and safe technology after the control of a clinician, after the control of Ptsd, and with the control of a neuropsychologist. Because the main aspect that technology is giving us is not only the motor control or the improvement of motor control, it's also the direct feedback after being treated with the technology. And this direct feedback, I can assure you, our data is confirming this, but all the international data are confirming this. Giving a direct feedback to a paraplegic patient affected by a spinal cord injury that can come back standing and then walking again on the ground with an exoskeleton is impressive in terms of neuropsychological achievements. Because we are at the same time treating disorder and all the depressive time that these patients are coming through after disease.
Yes, I think if I can try and summarize the points that you made there, the impressive thing to me about what you said is that you're giving your patients their life back. and you're in giving them the life back. It means that they are not so dependent. They can be have a more independent life, which can be based at home. And also, you raised a point very early on about the value of multidisciplinary expertise in developing solutions. We all need to work together to find answers to these serious problems, because I didn't realize until you were talking that there were such a large percentage of people who in the community who are suffering from these kind of conditions. So I'd like to bring in now Michael. I'm sorry that we missed you earlier on, Michael. I didn't realize that you'd logged on as a participant. You're too modest. You should log on as a panelist, and I know where you are. But we're going to give you, you look disgustingly suntanned as well. I don't like that. But maybe you'd just like to say a brief introduction, Michael.
Thank you very much, David. Thank you very much, David. And yeah, apologies about the connection earlier on. I came in on the wrong link, so I'm very sorry about that. I should know better. I'm a technologist. I've been in technology far too long to make a mistake, and apologies about the slow start. But yes, so I'm Chief Commercial Officer and Clinical Officer at a company called My Cognition. We've been involved in cognitive rehabilitation for a number of years, since the company started about just over 5.5 years ago. And a bit like this, it was discussed on the introduction earlier on, we take a very evidence-based approach to everything that we do. That's really critical. And we made sure that our technology was tested and certified and rigorously trialed through clinical studies before we even contemplated taking it into the marketplace. And I think it's really fascinating that the conversation that we're having so far about you know, where initially we do rehabilitation, and Paolo's absolutely right. You know, secondary care, hospital care is incredibly important, because that's where most of the severe patients with you know, cognitive impairment are rehabilitated, and that indeed is where we based a number of our clinical studies initially. Mm-hmm. So we're an R&D based company. We're based here in the United Kingdom, but we do have a number of deployments in the United States and Canada, and in the Netherlands as well. We haven't done a huge amount of work in Italy. We'd like to do more, so I've been talking to Lucia about that. But that's a little bit of a summary of where we are with our tech, and I can explain a bit more as we move forward with the conversation.
Wonderful. Okay, you'll get a chance to tell us a lot more detail when we move to the cognitive session. So I'm now going to ask Lucia to say a little bit more about the Rehability project. First of all, in the context of physical rehabilitation, what's the background to Rehability? What is it, and what can it do?
Yes, thank you, David. First of all, let me put one small detail straight, which is very important to me. Paolo, I'm not an engineer. I'm a mathematician. You should know that. And I'm very proud of being a mathematician. Okay. Rehability is our flagship product, and it stems out of two EU projects. Imaginary, my company is very heavily involved in European research since our foundation 16 years ago. So with two of these projects, we started looking first into neurological rehab, already with the aim of shifting what can be shifted, as Paolo very correctly said and pointed out before, towards a patient's home, and then also into MCIs, so elderly people with cognitive impairments and very often with comorbidities. So these two aims and these two populations very often go hand in hand, or the populations coincide, because very often elderly neurological patients also have MCI. So what we did in these two projects was developing in one motor exercises for patients post-stroke or with the degenerative pathologies like MS or Parkinson's, and in the other one some cognitive games. And then after these two EU projects, we engineered the whole sort of framework so that we can have a product where, as Paolo said, specialists have the therapy plans in their hands and set highly personalized therapy plans for each single patient, because personalized care is, of course, fundamental, and can check progress asynchronously. So when they have the time, they can check periodic data or specific data of a single training session. And in a separate part of the software, if I may say so, the patient has a training experience and plays the games. So we have patient feedback, which is different from a specialist feedback, of course, because, as Paolo said, also the fragility of these patients is very central in this kind of rehabilitation. So we have to take care that they are motivated, that they can access the exercises, also that they understand how they're doing. So for these reasons, and taking up again the point of multidisciplinary research, when we've been studying the solution since really the very first days, we've been conducting participatory design on two different ways, or on two different aspects, let me say. On the one hand side, of course, we worked with complete neurology teams, which means from the neurologists to all the types of therapies that are involved in taking care of these patients, to set up what we call doctor stations, so the specialists, half of the system. And at the same time, we've been conducting participatory design studies with neurology patients, because the games need to address this kind of patients. And there's an issue of motivation that can quite strongly support adherence to the therapy. So in other words, beware of a software house developing some games, thinking that this game is cool or this game I like a lot, if they don't involve properly patients into the design of these solutions, because that also brings you during the production process to change quite a lot of details. So in the end, we have 22 scientific papers backing up our neurology version of Rehability, and motivational indexes are very, very high. I would also like to add a couple of points to what Paolo was saying before, because on top of the advantages of using digital tech into rehabilitation processes, as you said, of course, super correctly, there are a couple of extra details there. One of the details, and I'm not even thinking of the extra stress that we have now during the COVID pandemic. So even in general times, there are very many patients and a few specialists, and very many patients who are not that impaired, I can say maybe, could really be at home, and they could leave more resources for patients who really need to be in the hospital. In other words, I was, for example, discussing with a huge hospital in Rome, in Italy, a couple of days ago, and this guy said, of all the rehabilitation areas that we have in the hospital, about 70% of the patients could be rehabilitated at home. 30% really need to be there to do their training with a specialist. So in other words, imagine not only the safety, especially today, of keeping 70% of the patients at home, but imagine the resources that you put free to take care of these patients. On the other hand, you can offer longer therapy sessions and therapy times, because when the time in hospital is finished, patients very often are left behind, but we're talking about chronic patients who could really benefit of much longer therapy times. And then the last issue is scalability. If you have this relationship one-to-one between a therapist and the patient, you have limited resources again. But if you put digital technology in the middle, which is organized and checked and monitored and in case tuned by specialists, then you can have a relationship one-to-many, which increases again the outreach that your team can have. So actually there's even much more into this than we think maybe at the first sight.
So you're using game psychology and games mechanics
Yes.
in your work. So can you take me through how a patient would be referred to something like, to use something like Rehability, and say with looking at physical rehabilitation to begin with, how do you know what exercises that patient needs, and what happens to, is the system calibrated so that it's set up so it can be within the capabilities of that patient? How does all that work?
Yes, well, first of all, I do not know it. Thank God there are specialists who know it. But what we did is mainly translating every motor exercise into a specific game, which obviously contains also cognitive stimuli, but mainly the motor exercise is translated into one game. So a specialist would know what kind of exercises the patient needs to do. So they put together a therapy plan, picking those motor exercises or those games, which set the base of the training for the patient. And then every game is parameter based, so that there are very many, let me say, degrees of freedom. Some call it difficulty levels, which is quite a tricky concept because everybody thinks of a level that scales up automatically, like in entertainment, which is not the case. Difficulty is a multidimensional concept. You have to tune the games exactly as you said to the effective capabilities of the patient, or the impairment, if you want to see it from the negative point of view. For example, for the upper limb, so for the arms, we have a calibration exercise, which means the patient needs to reach out, like I'm trying to do in front of my face now with the hand. So trying to reach with their arms all the four corners of the screen. And according to the coordinates that they can reach, which are probably not all the four angles, the games are re-stretched immediately to give him or her the possibility of playing with the whole screen, even if the movement is a very small one, like this. So like this, they could immediately reach the whole screen, and then probably the therapist would change the calibration bit by bit if the patient is able to improve, so that they are always brought to exercise at the border of the comfort zone. And then there are other issues to take care of. For example, with the lower limb, if you want to do exercises with the legs, you can set the exercises so that the step that the patient is taking in front of the screen is smaller or bigger, according also to the probability of falls or the actual possibilities. Or you can make elements in the game move slower, so that even your step is slower because it follows what is happening on the screen. Or you can set areas around objects in the game which are sensitive to the step that the patient is taking, which are bigger or smaller, same as with the upper arm. If you play, for example, putting food in pans, the pans can be bigger or smaller according to how fine-tuned the movement needs to be. So every game is really tuned in the last detail to the effective possibilities of the patient, because if it wasn't the case, then we would again break motivation.
Right. I've just had a question which is addressed to you, Lucia. Yes. It's from Loy Lobo. And what he's asking is whether the games have to go through regulatory assessment and approval. And is the game provider regulated in the same way that a healthcare provider organization?
It's actually a very good question, and the answer is not as easy as the question itself. In other words, until now, we didn't go through approval, and even hospitals, even public hospitals who used it, and I'm not talking only of Italy, I'm talking also of other countries, never ever wanted it to be CE marked in our case. In the meantime, there is a more, if you want, subtle issue, which is the following. For now, therapy, although this system is set to be used at home, so with remote patients, everybody has been using it within the hospital because of two reasons. Reimbursements were not clear and organizational processes were not in place. Since these things are moving and probably getting cleared and getting straight, now we will go, and we already started going through the CE certification for this system, because when therapists or specialists check patients' data, and according to patients' data or results of the games, if you want to call them like that, they change the therapy. This is a sort of clinical decision on the therapy plan, which needs to be certified by a CE marked device. So it's coming very soon.
Yes, I've noticed over the last couple of years that the FDA, for example, in America, they are starting now to recognize that games and software applications do have genuine clinical validation. So I can understand the difficulties with this in these early days, because so many people still think of these kind of exercises as a game rather than a genuine therapy. But you have done a lot of clinical trials with your system, I believe. Yes.
Yes, we have. So actually, probably also the reason why they wanted to use it, although it was not CE certified, I was reading the chat,
Yes.
was also that we had so many studies behind our backs. So we had really even on how do you say this very good papers, scientific papers, we had validation studies published there. Another difficulty was actually, and it's a bit still like that if you read the whole checklist and the whole paper work that you need to do to get the CE mark, you really realize that these people don't have a clue what a software is. They are always thinking of some sort of device that you can touch physically, and they don't have a clue what participatory design is. So actually there's some sort of well, misunderstanding in a way, and mismatch between bureaucracy and research methodology as usual. So it's not even easy to answer those questions.
Yeah, so it's quite a challenge. Well, I'm going to move on now to Michael, and we'll just go on to the cognitive rehabilitation. I will share a slide which has a screenshot from one of your applications as well, Lucia, but it also has a screenshot from my cognition. So I'm going to ask Michael to talk about my cognition solutions for cognitive rehabilitation, and go into a bit more detail on things like the certification and the validation. Michael, tell us about my cognition.
Yeah, thank you, David. So I alluded a little bit earlier on to it that we're an R&D company based here in the United Kingdom. And our trajectory has been shaped by the regulatory environment and indeed the clinical environment over here in the United Kingdom. I know we talked a little bit earlier about rehabilitation in dementia and stroke and mild cognitive impairment. And what we've done clinically here has been dictated by organizations like NICE, for example, which did produce some guidance many years ago and did a revision about 4 years ago, which stipulated that the computerized cognitive behavioral therapy should not really be used or recommended for dementia patients, which was out of kilter with some of the thinking and recommendations that were being sort of undertaken in other European countries and in the US as well. So that sort of dictated a little bit about where we went as a cognitive company. So we decided to approach the whole subject of cognitive impairment and try and better understand it. To develop a way of assessing people's cognitive performance and then making decisions about what strategies we might deploy to try and improve their cognitive performance. So what we did is we built an assessment which we call MyCQ, and it's My Cognitive Quotient, and it's a trademarked assessment. And what we do is we assess 5 cognitive domains in the brain. Those are your executive functioning, your working memory, episodic memory, speed and accuracy, and attention. And those are 5. There are 5 established methodologies for assessing those, which have been universally accepted. And what we did is we effectively digitized those and put them into one simple app. So we can now test people's cognitive outputs with a simple application that takes literally 15 minutes. And it's accessible for people with very mild cognitive impairment all the way up to people with moderate dementia. We've even trialed and tested it in patients with Parkinson's, with mixed psychiatric disorders, children with behavioral challenges, PTSD, sexual harm, as well as people with a whole range of other morbidities, for example, oncology, diabetes, cardiovascular disease, respiratory disease, and neuromuscular disorders. And we can now identify exactly the kind of cognitive output that those individuals have. And we know that those difficult physical conditions will affect their cognitive output as well, which is incredibly important, because there are a number of other clinical studies that have been performed, not by us, but by other academics, that show that long-term conditions do have an impact on people's cognitive performance. There's a rather famous study which has been going on for a number of years called the Longitudinal Diabetes Study, which shows that over 50% of type 2 diabetes have got cognitive impairment, which is affecting their ability to self-regulate and self-manage their condition. And if unchecked, it will just get increasingly difficult for those people to look after themselves and self-care. So we have taken a position with our assessment tool to measure the impact of cognitive impairment, predominantly in the primary care setting. And it sort of rings true a little bit what Paolo was saying about we need to move services back out into the community to help people. We've taken an approach looking at the population in the community and then following them as they move through more specialist services in secondary care and hospital care. So we know that we can now quantify and assess cognitive impairment. And that's really, really important, because up until now, the only exercises or methodologies they had were the paper tests, which have been performed and still are performed in hospital scenarios, particularly around dementia assessment with, say, the Stroop or the Mocker test. So we validated our test as well against a number of established gold standards, and we come out as just as efficacious and just as accurate as those in predicting what people's cognitive output looks like. What we've also done, though, and this is really important, and this sort of feeds on to what Lucia was talking about earlier on, we've developed a game, a computerized game, which is set to the data from the assessment. And we've taken a view that if you're going to give people a computerized game, you really need to try and personalize that experience to the individual. Because if you can personalize it and personalize the components of the game, you'll get a better cognitive improvement. So when it comes to the question around certification and regulation, it's a really interesting point, David, because some computerized games, which are single modality, single cognitive domain, are not based on algorithms. They don't have difficulty or intensity algorithms or training loop algorithms built into them, whereas that's exactly what we've done. We've built algorithms into our computerized game, which means, therefore, that it would be subject to regulation, which is exactly what we've done, and it's regulated as a medical device by the MHRA. Now, what is important is that in our game, which is designed to be fun and a fun experience for people, entertaining experience, and also it's based on calm principles as well to keep people centered, keep people focused, is that we can demonstrate significant improvement in people's cognitive domains. The ones I mentioned earlier on: working memory, episodic memory, speed and accuracy, executive functioning, within 8 to 12 weeks. And the reason why we do that is because the game is designed to train all of those domains all at the same time. But the experience for each individual is very, very different, because the MyCQ data sets the personalization of the algorithms. So we've like Lucia, we have a number of clinical studies and feasibility programs that we've done. In fact, I think it totals something like 52 at the moment, studies that we've done in a whole range of different kind of patient type, including oncology, because that's another big area, because we haven't touched on the subject matter, that a lot of the treatments that we provide to people, or ineffective treatments that we provide to people, actually cause cognitive deficit, and it's contributing to mild cognitive impairment in the emergence of that in older populations. And so we've done studies in breast cancer in particular to show that we can demonstrate an improvement in cognitive output as a result of chemotherapy interventions. So that's a little bit about what we've done with the application that we've developed. I think what's important to recognize in terms of the scalability is that we designed it as an app that people could use on any mobile device, whether that's their preferred mobile phone, or whether that's a web browser, or whether that's a tablet. So it can be used in lots of sort of clinical settings and home settings as well. So that, and even at work, because there is there's a version of our app that can be used in the workplace to try and improve productivity and address mental illness. And that's another factor which we haven't really touched on, actually, the importance of cognitive rehabilitation, the importance of cognitive impairment, because it does have a direct correlation on the overall mental health of the individual as well. And it is one of the single biggest risk factors for people developing severe anxiety and depression. And we know that link to be true. So everything we can do to keep people as cognitively fit and as mentally resilient as possible puts us in a better position to be a healthier mental health population.
Yeah, and of course in the UK we have Liz Ashall-Payne's organisation, Orca, who do a lot of validation of mobile applications, and you've been through all of that sequence. So primarily the solutions that you're talking about have their origins in clinical settings. So a lot of the assessment is actually done in a clinical setting, presumably within the presence of a physician. And I've got a question here from Tim the Magnificent or Magnificent Fallsman, and he's asking about the PTSD and problems that veterans have when they come back from missions, or they come out of the forces and go back into a home environment. And on one of our recent webinars, I remember Leslie Robinson saying something that lockdown is causing very similar PTSD symptoms to the kind of symptoms that veterans suffer from when they come back from a mission. So do you see this as a big problem as we exit from lockdown? Are a lot more people going to have medical problems? Will they all have to go to a clinical setting to be assessed and have treatment?
Well, if that's directed at me, the challenge is that the healthcare systems will now have to manage the contact that they have with individuals moving forward. I think that's a given. So that in itself sets up a bit of a difficulty in delivering face-to-face services or face-to-face support interventions. So organisations like the NHS in the UK are clearly thinking about the kind of digital applications that they could use in order to try and address some of these challenges. And so it opens up a great opportunity for a company like MyCognition, because it doesn't need to be administered by a physician. So what we effectively do is if we have the contact details under our GDPR compliance policy, if we have the details of the individual, we literally send them a link and they download the application onto the preferred mobile device, and then we can monitor them in the background in terms of the usage. And if they're part of our coaching service, then they can have one-to-one coaching and periodic interventions by a coach over a period of time to make sure that they're supported. Or indeed, they could be supported by a healthcare worker within the NHS environment that they're currently being managed by. But ultimately, they would then use the application in their own home to try and improve their cognitive performance and address their cognitive challenges. So that's how it could be implemented there. PTSD is a really interesting one, and it's sort of been mooted as a bit of a silent killer, to be honest, because we just don't know the extent of it. But you're absolutely right. I mean, there was a study done when the SARS virus came out several years ago. And there was a clinical study done of over 150 individuals, of which some of them were veterans, believe it or not, within the veteran service in the US. And something like 60% of those veterans that didn't have a previous diagnosis of anxiety or depression all reported in depression at the end of the evaluation. So yes, the restrictions that we're seeing on people is having a PTSD impact on them, definitely. And we'll only start to realize that as we move forward, unfortunately, when people start to realize that they do have an issue or they have a problem. The United Kingdom now is going through a process of putting out tenders to digital tech companies in certain themed areas. There was there was a tender that went out for children and young people's mental health, and there's soon to be a new tender coming out in the next week or so for adult mental health, people in crisis, people with PTSD, people suffering in isolation. So they're very acutely aware that there is going to be a demand for this, and they're priming companies to be able to respond to that.
Yeah.
So it is a really interesting point that Tim mentions.
Yeah. I'll kind of bring in Paolo. We haven't seen Paolo for a little while. I'll go back to Lucia in a second. So Paolo, looking at the psychological impact of these conditions, and the fact that with the help of your technology, you can give people their life back. Do you find that your patients get dependence on technology, which makes it difficult for them to go back?
Yes, David, thank you very much. And thank you, Michael, that has focused a bit on about this problem that is quite important. All neurological disorders are related with psychological disorders, okay? Because we are suddenly losing our opportunity to move our hands or legs or being back in our life. So it's quite important that we are giving them the opportunity to restore their own function. Okay, and technology is giving us this opportunity. So it's quite good, but at the same time, we have to be quite alert because we are changing their own life, okay? There is a lot of people coming to my hospital being on a wheelchair, and after being worked on an exoskeleton, now is back to walk on the ground, but not with their own legs, but just with their own legs applied to technology, that it's a bit different. Mm-hmm. So we have to focus a lot about these aspects. This is why we are working with our neuropsychologists about all the aspects, all the pathologists treated with technology. And we have seen that a lot of patients want to come back immediately after being discharged to being treated again with technology. This is why I embraced with an enthusiastic way the theory and the work of Lucia to be again the opportunity to our patient to be treated at home and continuously have rehab motor training rather than just coming within an hospital, because we are discharging our patient, okay? So we have two items, or I'm just giving them a letter with diagnosis, okay, paraparesis due to spinal cord injury, or I am a neurologist applied to rehab, or I'm giving them the opportunity to come back to their own life. So not only a diagnosis, but also the opportunity to work again, with or without technology. This is quite important to come out from the hospital with new technology as well at home. Otherwise, it's just a way that it's tuning on itself, okay? The patient is discharged, then he wants to come back again to the hospital to be treated with technology because our health system is not giving them the opportunity to continue their rehab. And this is a quite tough system. This is very impressive, okay? Because we are changing the feeling of their own body. And then we are discharging this patient after giving them the opportunity to work again with an exoskeleton, but then they are coming back on their car, on their own wheelchair. Completely two different things that are quite tough to have been accepted from their own patient. This is why I believe that technology is now giving us the opportunity to go across all the single aspects. And this is why a quite important technology being applied at home as well.
Yeah, I think that's an excellent place to bring you in, Lucia, to say how your work carries on from what it takes place in primary care in hospitals. I remember, I know it's not quite the same thing, but many years ago, my father had to go into hospital for quadruple heart bypass. And he was only in hospital for a couple of weeks. But whilst he was there, he told me about patients who were due to be discharged and they couldn't leave the hospital because they had become so dependent on it. And I guess there is that space between the hospital and coming to the home environment where all of a sudden they go from being in a situation where they've got a lot of support into a situation where they're losing their exoskeleton, perhaps they're losing some of the tools which have empowered them to feel that they can get their life back. Is that the kind of experience or the kind of solutions that you're wanting to provide by providing rehabilitation at home?
Well, what we're doing certainly goes into this direction. Clearly, our technology is not what Paolo is talking about. I mean, Paolo is talking about an exoskeleton, and if you take the exoskeleton away from this person, probably this person is not able to walk again. So it's something that, at least for a certain period of time, which I fear is quite long, if not permanent, is fundamental for this person. What we have or what we offer is a strong facilitation for this person is the way to train, but it's something that people in a way can live without, clearly. I mean, it's not that people can walk or not walk with or without our technology. It's not that that strong, that the impact of our technology is not as strong. Clearly, if you train more, you can get better, or you can slow down deterioration, which is unfortunately a very good result for many people. What certainly goes in line with your way of reasoning, David, is that when you're discharged and you feel suddenly the whole team of people, of specialists who was taking care of you is letting you go and you have nobody anymore. Actually, with our system, you continue seamlessly to do the same things at home that you were doing together with your therapists in the hospital, and you can do that on your own or with a simple carer. But you have the feeling that somebody's checking on you, because you know that the plan is prepared and you know that people are checking your data. So although specialists are not present at your side, you feel they're there for you as well. So I guess it gives a sort of feeling of being cared for, although people are not physically present. And that's very important, because as we said before, these people are fragile and we never have to forget that.
No, absolutely. I think you're perfectly correct. And I think this is where the technologies that we have available today may well help us to get through this terrible coronavirus situation, because we are able to be connected to the people who can support us. And of course, it's very important that these technologies are personalized. As Michael said, they got algorithms which enable them to personalize the treatment according to the data that's read from it. And this is the same with your technologies. We're about 5 minutes away from the scheduled completion time. I just want to ask each of the panelists in turn what they see as being likely new developments in technology which are going to affect the kind of work that you do. What can we look forward to, Lucia? Will the developments in 5G or other technologies make a difference to?
Well, I think a bit of everything, because of course, if bandwidth is supported better, then it's much easier to connect people from home, because what we're offering needs an internet connection. On the other hand, AI, artificial intelligence, is definitely likely to support. I don't think we will have systems that auto-tune the therapy plans for patients without the need of specialists. But what you can do is suggest to specialists what could be changed, so that you facilitate their job, and then they confirm or reject solutions that are suggested by the system. But anyway, AI can support that. What I see as the very first step is actually more into the direction of connected care. So I see we have plenty of potential, we have plenty of solutions which are working nicely, but everything is a bit scattered, and we have bits and pieces everywhere, which often don't talk to each other. What we need to do now is pick some of these nice bricks that are validated and useful, put them together and start deploying solutions. And then we can build the next step.
Yeah, I think that's a very important observation. Paolo, what can you see in your field of work as being likely developments in the future? How's technology going to help your work?
I think that I completely agree with Lucia, but I think that we are just on the step, because the main goal that we have achieved now is that we are working in the hospital, at home, and everywhere at the same time. So we are speaking each other, and COVID has taught us that we are able to be connected. I think at the same time, we can imagine that our patient can be connected with their own brain or spinal cord as well, using technology at home. And this is the main aspect that we have to develop and we have to focus on. I've developed a program called Working Over Disabilities. When I'm teaching my patient to work with their own exoskeleton at home, I believe now that costs are very high, but at the same time, we have believed 10 years or 20 years ago that we would have never been able to play with serious games at home and learning to move a hand, arm, on being able to speak again, or doing a cognitive improvement using technology at home. So I think that we are on the right way. We are absolutely on the right way. We have just to push on the accelerator now. And I think that this COVID has been really a bad aspect of our own life, but it can represent now a very good opportunity to fire on our accelerator, because we need to achieve the best result in the meanwhile. Okay, now we were stopped at home, now we are again working, breathing, also using our masks, but I think we are more connected with our brain and with our technology. So there is a lot of patients still arriving in my hospital, learning how to work with an exoskeleton, and I'm pretty sure that these patients soon after will be able to work with their own exoskeleton across their own cities. So this is the future, but I don't think it's so far from us. Okay. Yeah. So we have already spoken about this in China. I think that we are be able to speak about this with Lucia and Michael as well. In terms of cognitive disorders, motor function needs to come back again, and we are able to do this. And I believe I am a neurologist, and I think that technology has completely changed the opportunity to treat our patient, okay? Not only in the ICU, but as well within a rehabilitation unit. Because using technology, you are treating motor dysfunction, and at the same time, you are treating your mood disorder and cognitive disorders as well. So we have just to put together all our efforts and trying to give us the best results.
Yes, we need a very holistic solution. And finally to you, Michael, your thoughts on this subject. What are you likely to see in the future? Are we going to see a more holistic approach with more connectivity between these types of applications?
Well, you know, we're talking purely about, you know, cognitive rehabilitation here, but the digital transformation is affecting all of healthcare. So, you know, when it comes to stroke, for example, minimizing stroke, we're seeing a lot of digital technologies being used to try and identify, you know, people with arrhythmias to improve medicines compliance, medicines adherence, which all have an impact on reducing the impact of stroke and the number of people that go through that process. And we're also taking that a preventative approach in our business too, because we want to try and improve people's cognitive performance before they get really sick. You know, I know we've talked very clearly about people at the one end of the spectrum, dementia and stroke rehabilitation patients. But you know, if we can start to reverse the trajectory of cognitive impairment and maybe change the trajectory for, you know, dementia and Alzheimer's, then that's going to be a better healthcare and societal gain, actually. And that's where we're positioning ourselves, and that's where we're looking for partnerships in that space too. Because the more we can do there to try and affect the decline and maintain people's cognitive health state for as long as possible, the better the result will be. When we look at all of the health economies around the world, what they're trying to do is to give us the end of life that we have, the 5 years, they want it to be the best it possibly can. And if we're going to possibly do that and give people good quality of life and high quality of life, then we have to address their cognitive performance. But we can't do it on our own. We have to work with partners and other solutions to make sure that we do personalize whatever we give to people. And Lucia is absolutely right. We need to have a better ecosystem and a better suite of offerings that clinicians like Paolo and organizations can use so that they can tailor the best possible outcome, the best possible solution for the patient. But what's really, really vitally important too is that we're capturing the data along that trajectory so that we can then personalize it more effectively and then look for what the population outcomes are, so that we can take a more public health and a more preventative approach to that. And the only way we can do that is with big data. And the AI algorithms are incredibly, the AI is incredibly important for that. And we're working with a number of organizations to try and do that. So I think that's what my thinking comes from. It's around the bigger data piece.
Mm. Well, I'd like to thank all of my panelists for their wonderful observations, and also to the participants in today's webinar with your questions. I think we've had a very good discussion. The observation that possibly I would like to make is that COVID-19 has been a terrible thing for the world, and we probably yet to see the worst effects of COVID. I think we're likely to see some really bad effects as a result of the damage to the economy that this has all done. But in a way, COVID-19 has given us an opportunity to try a new way of living, to try to use technology to connect to each other better. So in a way, it's provided with an opportunity to make a better world between us. And discussions like this give me a great deal of hope that we can come out of this and have something more positive. I just want to end by saying thank you again to all of the participants for joining us today. I just want to finish off by showing you, putting up a couple of slides just to show what events we've got in the pipeline coming up. We have a New Normal Networking Friday. It's every Friday afternoon at 2 o'clock. It's very informal. There's no obligation to attend. I will be here even if I'm on my own. I will wait to see 15 minutes if I get any mates come to join me. And we can have a good discussion about what we've heard today. And also maybe to look at some of the things that I'm thinking about in the future. Next week, next Tuesday, it's going to be something slightly different. It's not going to be a panel discussion. I'm going to try and strut my stuff a little bit and talk about gamified immersive learning. I've described it as a masterclass. I don't want anybody to get the impression that I am a master of the art, but I would like to show a few new tools which I think could have very useful application, particularly in an area that I'm interested in, and that's digital heritage, and the use gamified environments to get people interested in local history and become more involved within their local community in those activities. So that's next Tuesday at 2 o'clock, and you can find details of all of our events we've got in the future on the 360 and 360 website. I won't leave it quite at that. I will be sending out emails towards the end of the week to everyone to remind them of what's in the pipeline. And I hope to see you on Friday, or if not, maybe next Tuesday. So thanks once again to my superb panelists. They always deliver. And I apologize to Michael that I didn't look for him earlier. I just assumed that something terrible had happened to you, Michael. I'm glad it hasn't. So thanks once again, and look forward to the next event. Thank you. Bye-bye.
Ciao.
Thank you. Ciao.
Bye.